Hi, Felice Shapiro here from Better After 50, and I am speaking with Dr. Susan Hardwick-Smith, who has an incredible center in Houston, Texas, called the Complete Women's, I want to get it exactly right, the Complete Midlife Wellness Center, and
Got it.
it's bursting at the seams. I mean, I think you're opening a second one now, right?
Right. Yes.
That's fantastic. And I have been, I think I spoke over a year ago to Dr. Susan, I'm going to call you, if that's okay, uh,
Please.
about many topics relevant to women BA 50s and 60s and 70s. And she is a wealth of knowledge. And today we are specifically dealing with the topic of menopause and after, the truth about hormone therapy every BA 50's right to know, which was in response to a New York Times article written on in the beginning of February, which blew this conversation wide open to Dr. Susan's delight. Dr. Susan, do you just want to speak about that article for a second? Because it was pretty amazing.
Yes. Hi, everybody. So Sue Dominus, who's an amazing journalist for the New York Times, published this piece on February 1st. If you haven't seen it, I actually happen to have it sitting right next to me, and it's called "Women Have Been Misled About Menopause," which I thought was such a great title because it just is. When I saw the title, I thought, oh, thank God someone else is going to talk about this. And so if you haven't read it, Felice will hopefully put a link somewhere where you can find it. It really is terrific. What the article speaks to is just why are we making these decisions, or why are doctors making these decisions for us based on a study that's more than 20 years old now and really has been shown to have had a lot of flaws in it. And how can we approach discussion about menopause and hormone replacement in a more modern way, taking into account a lot of studies that have been done more recently, as well as the lessons we learned from that older study called the Women's Health Initiative, and just rethinking some of the rules that our doctors have told us. And I know many of you might have heard these, like you can't take hormones when you're over 60, or you can only take it for 5 years, or hormones cause breast cancer, or you name it, all of these different rules. And so all of those are gray, or closer to white, perhaps, and not black and white. So I just wanted to chat with you about that and how we can be a little bit more flexible about opening up the conversation about offering hormone replacement to a much wider group of patients, because it's so helpful. I take hormones myself. It's changed my life in so many positive ways. And it makes me so sad that many women are not offered this very simple, available treatment that can really be life-changing. And so this article really shed light on that, and then just opened up a whole bunch of different discussions that we're going to get into some of that today. But yeah, give it a read. It's just really a must read for everybody who's in our age group. I'm 55, and yeah, as a physician and a patient at the same time, I feel uniquely positioned to sort of talk from both angles, because I've had these symptoms. I've been a menopausal woman. I am a menopausal woman. And I also talk to patients all day about these questions. So it's really fascinating, and so grateful that you invited me to speak to your listeners.
Yes, and I have some really specific questions for you, because I did post the link on Better After 50 and on Instagram last Monday, and we got over 50,000 views on it. It is a hot topic with over 100 comments. And I wanted to actually speak about some of these comments, because I think it steers the conversation into toward what people are specifically looking for.
Mhm.
So for our audience that is, you mentioned this, over 60, who have missed the 10-year window that we were told we could not take HRT, which I was told about 2 years ago. I missed it. And now I'm learning that I can, and there's a lot of reasons, and you can read the articles to understand what those reasons are. We don't need to go through that again. For some of us who are not having hot flashes, but have other symptoms, such as bone health issues or thinning skin, or maybe the memory could be jogged in a better way. And there's so many benefits that sound almost like, well, you're aging, like, who cares? This is, you should just deal with it. But
Right.
when I look at the responses of people who are on it, on Instagram, and listen to you, which is just kind of like a well, maybe it's even a bigger focus group than some of the studies have had, but it's not necessarily scientific. I wanted to ask you specifically, when you go to your doctor, if people are saying like they're on it, like this one woman, January Scottsdale, as her name is, who's 65, been taking hormone implant pellet for 7 years. I feel like $1,000,000. I'm better off than 40-year-olds. Okay, that is really the tone of many of the comments. And these women are over 60.
Right.
So
Well, I'm also a patient who has pellets in my system and have had, so I'm 55, as I mentioned, started at 47, and I feel a lot better than I was 30. So I agree with that patient's perception. I share it. So yes, we feel better, which is critical. And so yes, to not interrupt you too much, because I'm so excited to answer your questions. But yeah, what do we do in order to see if we can have this made available to us, and what questions do we ask our doctor? Those are really
right.
important things to think about, because many of us, and many of your listeners, I'm sure, have asked questions that they thought were appropriate, or said, well, can I take hormones? My friend feels great. And they've been told, no, you can't, because you're over 60, or you didn't start within the first 10 years, or you name the reason. So there's what the article really spoke to were several points, but one of them was the very, very sad lack of education that gynecologists have about hormone replacement. So if you're going to your general gynecologist, unfortunately, with very few exceptions, I think it's wise to go in there expecting that they know very little. And it's sad to say, but that's really the truth. We're not taught anything about this unless you've done some postgraduate education. Your doctor's not going to know anything. So first of all, find the right person to ask. So perhaps looking at the North American Menopause Society website could be a good start. Your general OB-GYN might not be the right person, or they may, just depends. So you need to find the right person to ask, and that would be someone who has taken the next step to get some additional education specifically around menopause. So the NAMS website, which is menopause.org, is a good resource. You put in your zip code and find somebody. Now, just a word about that. To be a member of the North American Menopause Society simply requires writing a check every year. So membership is not any great difficulty, but there's a higher level of specialty called a North American Menopause Practitioner. So look for that extra letter P at the end and find somebody who has that designation. And they would be someone like myself who's done a lot of additional education, and they're more likely to know more and give you better answers. So that's one tip.
Okay, that sounds really important. So find the right doctor. Once you have found the right doctor, what is it that you are? I just think, am I a candidate, or are you? How specific can we get with the questions? Can you help us with the questions?
So this is a tricky time where we're asking patients to really be their own advocates and go into the visit with a little bit of an agenda. I hate that this is the case, but I think this is what we need to do if you want to get things done, ladies. You've got to advocate for yourself. So certainly go in with a specific list of questions. You may be seeing a doctor who only allows 10 or 15 minutes for a visit, unfortunately. So we've got to really make use of that time. I would definitely go in with a list written down of what your symptoms are. And in my office, you'd be given a symptom checker, and we'd ask you hot flashes, night sweats, joint pain, vaginal dryness, memory loss, et cetera, et cetera. But if that's not offered to you, go in with your own list and say, here, this is what I'm having. I've read a lot about hormones. I've listened to lots of podcasts and things. I would like to start taking estrogen. Could I please have it? And then I would wait for a few seconds and see what happens. And if that person says NO without asking you any other questions, I would probably say thank you very much, and then just walk out and go down the list a little bit further to find the right person, because there at least needs to be a conversation around it. And I get very annoyed personally when I am shut down, and you may share that too. You deserve to be listened to. And that means asking a lot of questions about your specific symptoms, your specific health situation, not just giving you a black and white answer like, no, you cannot because you are 60 years old in 1 month. That is based in no science whatsoever. So it's a sad situation, but we really have to advocate for ourselves. Find someone who will listen, go in with a very bullet list of your symptoms and what you have learned, and ask for what you want. And excuse me, sadly, many doctors are in such a hurry that they're more than happy to give you what you ask for. That's why they put ads on television for drugs. You know, we're living in a world where patients can drive their own healthcare if they're very educated and have the gumption just to keep pushing forward, because I think with very few exceptions, estrogen in particular, as well as progesterone and testosterone, I take all three, have enormous health benefits. And there are very few women who should not take them, very, very few. In fact, pretty much everybody's a candidate with a tiny number of exceptions.
Okay. This one woman, Barbara Kame, commented, I'm 79 and on a hormone patch. It works for me. Let's just say I asked my doctor, 79. Wow. She probably didn't start. I don't know when she started, but that was amazing. Anyway, the question is, am I asking for a hormone patch? And since I've been reading so much about it, there seems to be a conversation if you've had a hysterectomy or you've not had a hysterectomy. So what I've learned is you don't just want the hormone, the estrogen, you have to balance it out. But I shouldn't be telling the doctor that. They should know that. So wouldn't that be another like quiz question to see if they like understood what was going on?
You know, I'm so sad to say, but you kind of do need to know this. One would think that doctors would know this, but you know, in my training, I was trained how to deliver babies and handle emergencies, do hysterectomies, manage birth control, etc. Taught nothing about menopause. So hopefully you'll find someone who has enough education to know that we do want to give progesterone along with estrogen for patients who have a uterus because it prevents uterine cancer, which is a great benefit. I actually give progesterone to patients who've had a hysterectomy because it has other benefits like helping with sleep, mood, anxiety. So there's a lot of different ways that hormones are available to patients, and it's not one black and white, one fits all solution at all. And that's why it's really important to find someone who will listen to you. But I love that comment from a patient who's, you know, significantly past menopause. I plan to be using my estrogen until I die. And I hope she does too. There's absolutely no reason to stop it, with exception of a very tiny number of health issues. So taking it long-term is a great idea because we know it reduces osteoporosis risk, Alzheimer's, heart disease, colon cancer, sexual dysfunction, skin dryness, vaginal moisture. The list is very long. So we wouldn't want to stop it right when the risk of those things is the highest, because as soon as you stop it, bone loss starts to accelerate, all of those problems kick in. So we really want to be on it from, if possible, within the first 5 to 10 years of menopause throughout life. Hey, but it doesn't always work out that way. So if you didn't have the opportunity to start on it in the first 10 years, that doesn't mean that you cannot. It just means, you know, we want to go through some questions and kind of see where you are, because every person's different.
Okay, well then, so you answered Julia's question, which is more on this topic, please. Discussing how long to stay using the therapy beginning age 60 beyond 10 years of HRT. She will hear that you are going to take it until your last day on the planet.
Yes. So just really quickly, because I know this is such a deep topic that we could talk about, I'll try to skim the surface. This idea that became widely promoted that there's a 10-year estrogen window was based in the findings from the Women's Health Initiative study, which indicated that the women who started on estrogen when they were over 60 had a minuscule, some people argue not even significant, but let's just say it was a slight increase in blood clotting events, blood clot, heart disease, stroke. Now, these were women taking a drug we don't use anymore called Premarin. They were taking it by mouth. And they were a very unhealthy group of patients. Average age was 63. They'd have previous heart attacks, smokers, obese women, you name it, anybody could be in that study. So they were not patients like you, Felice. They were not patients like me. And we don't take estrogen by mouth anymore because we know that it can increase blood clotting events. So when we use it in any type of non-oral form, like a patch or a pellet or a cream or anything that's not a pill, that blood clotting risk doesn't exist. It's not increased, so to say. Of course, anybody can have a stroke or a heart attack unrelated to hormones, right? So we're dealing with a baseline of these health issues. And the question is, does hormones increase them? And actually it does not if you don't take it by mouth. So the idea that you can't start hormones after 60 is true if the statement was put this way: don't take oral estrogen. Don't start oral estrogen when you're over 60, or don't start it anytime. We wouldn't give oral estrogen to anybody anymore. So it's a misunderstanding of the study compared to where we are now, because we don't use the same product. It was a different group of patients than most of your listeners. And so we just can't apply that logic to every person. It doesn't make sense. That's not how humans are. So by all means, if you're using a non-oral type of estrogen, you can certainly consider starting it when you're over, you name the age. You won't get as much benefit as when you started earlier, but hey, I think that's like saying, don't bother putting money in the savings account because you're 50, you should have started when you were 20. Well, yeah, it would have been great if you started saving when you were 20, but it doesn't mean you don't start.
Well, that's what I was told, but I'm really glad to know that
Yeah.
it's not the case. There are a couple people that I spoke with since I posted this whole piece last week, who have had breast cancer. And I said, I have been doing some research and you should talk to your doctor about it, because apparently you can still take it now. It was not for me to say, they have to talk to their doctor, but you're saying that is not a conversation stopper. Like
Oh, no, it's not. So nothing's black and white, even if you've had breast cancer yourself personally. It depends on the situation. I'll just make up a situation because there's so many variables about types of cancer, stage of cancer, the treatment that was given, and so on, that would make that a very individual conversation for each patient. But that being said, I can't count how many patients who've had breast cancer who are taking estrogen in our practice, and that was a very good decision for them. So it's the short version. If you have a stage 0 or stage 1 breast cancer, it's a very early stage that has been treated and it's gone, and you're more than a couple of years out from treatment, there's no evidence that taking estrogen is going to increase your chance of having a recurrence. If you're in that group. Now, certainly there are exceptions to that, but just to say the answer isn't always no. It should be, let me look into that a little bit more. And then there are other options for breast cancer patients, like taking testosterone, for example, which we know reduces the incidence of breast cancer recurrence and does relieve a lot of symptoms without even taking estrogen. So even for the naysayers, so to speak, there's still other options. And so I get really annoyed when people say, or doctors say, you can't take any hormones. Well, that's a broadening of the truth, which is that we need to be careful thinking about whether you should take estrogen, but you certainly can take testosterone, for example, and you could use vaginal estrogen if you have dryness or pain with intercourse. So it's not like NO, it's like, let's look at what's possible. Instead of telling you all the reasons why you cannot do something, let's look at all the options for what you can do and how we can modify this to make it safe for you.
What about, okay, that sounds like a wide open conversation that many of these readers and people I've spoken to would probably welcome to have with the doctor who can answer the question instead of the big NO. The other thing is people talk about UTIs and HRT. What is that correlation? Yeah.
So when we're estrogen deprived for some period of time, as many of you have experienced, the vaginal tissue gets thinner, it gets more dry. Just normal activities like intercourse can cause little paper cut type tears in the skin, allowing bacteria to get into the vaginal tissue, even into the urethra. So there's an increase in urinary tract infections. This term, we used to call it genital atrophy, which sounds so awful. And now it's been modified to genitourinary syndrome, which is a fancy way of saying when you don't have any estrogen, the genital area, including the bladder, just don't function very well. So we have dryness, pain with intercourse, urinary tract infections, other bladder issues like urgency or stress incontinence. So the pelvic area is flooded with estrogen receptors. So when we take estrogen away, absolutely all of that's affected. And we put estrogen back, all of that goes away. So
all the issues go away.
Right. And I love in the article, those of you who read it, there's a little introduction where she says, if men had this happen, if they had something happen where their penises got dry and itchy and they had pain with intercourse and urinary tract infections and they couldn't have an orgasm, and there was an easy treatment that was also proven to be safe, would anybody tell them they couldn't have it? Not a chance, right? But as women, we're still facing these sort of patriarchal cultural ideas where the doctor tells you what you can do or what you can't do. But I just thought it was interesting to think about. Like,
Well, it's really easy to talk to you because there's a very like-minded feeling here. And I think our BA 50 is going to love hearing this. We will continue this conversation. I want to make sure that our readers know how lucky we are to have Dr. Susan Hardwick-Smith share this incredible, groundbreaking. It really does feel groundbreaking. To you, it's not groundbreaking. To us, it's groundbreaking. You knew it all. You've known it for a long time, but we're feeling brave enough to go back out and ask again. May we have it if we think we need it? And that is very empowering. And we are beyond grateful for that. So I also want to share, if you want to speak with and meet Dr. Susan, she's giving a retreat. Can you just tell us a little bit about that retreat?
Yeah, so I'm a co-host of this amazing adventure. It's the first weekend in May 5th through the 8th. It's at Miraval in Austin. And many of you may know that brand is fabulously luxurious and just a lovely place to be. So we'll be there Friday through Monday, myself, and we actually have 6 other amazing hostesses. Some of you may know who they are. We can put their names below. Dominique Saxa, many of you might know, will be there. Okay. Elaine Turner, who's a designer who's now moved into midlife coaching. We've got some fabulous life coaches, yoga, meditation instructors. Long story short, it's a midlife women's celebration. And we'll be talking about everything to do with midlife. My part in it will be talking about issues like this in small groups, no more than 10, where we can talk, on the grass, on a yoga mat, not in a conference room, no PowerPoint slides. We're just hanging out, spending time with women in our age group, sharing our stories, sharing our knowledge from the aspects of these other hostesses as well. So we can put a link to that below. For anybody who knows about these kind of retreats, they're expensive. And the first thing that comes to mind when you look at it is, oh my gosh, that is a lot of money. And it is. And I'd like to tell you it's going to be life-changing, transformative, and you are worth it. So check it out. And if you do sign up through this interview, just let us know and we'll give a $500 discount to anyone who mentions Better After 50, because we just want you to be there. I wish everyone could come. It's only 30 spots. I think we have 4 left as of this morning. So jump in and come visit, and you can sit and chat and have some yoga and coffee and a glass of wine and just warm, fuzzy times.
That's fantastic. Okay, so we'll be posting this on our YouTube and also on our site, on our social media, and we welcome any further questions, and the conversation will continue. Thank you so much for your time.
It's my pleasure. And please check out my YouTube too. I talk about hormones a lot, and so this is a lot to talk about. If you are interested in getting into this a little bit more, lots of pieces I posted on YouTube, on my website. Educate yourself, stand up for yourself. Don't take no for an answer. Go to the next person. I'm sorry that we have to do that, but you deserve it. We deserve it. We deserve it.
We do. We do. Thank you.
So good to see you. And thank you, everybody. I hope to see you all or at least a few of you in Austin in May.
Great. Bye-bye.